Good afternoon, everybody. What an excellent morning. Thank you very much indeed. It's been heart-rendering, inspiring, and also incredibly insightful into the needs and the experiences of men, women, children and young people, girls and boys, as part of their experiences as part of rape and sexual assault and domestic abuse. I'm Kate Davis. I'm one of the national directors in NHS England. I have the privilege of being the director that also commissions sexual assault and referral centres. And I'm going to take a little bit of an embarrassing moment because I can. There are 4 women that are sitting over there, Angie, Zilla, Nicola and Esther, who actually are the 4 women and the team that support, develop and commission the 47 sexual assault referral centres across England. Yes, there are only 4. Esther and I were talking, I think, earlier today that going back to Laura's comparison to your daughter and her now being 7, that Esther and I remember really clearly back in before 2016, really having the want, the need to commission this work. And to sit here and see this at this point is incredibly humbling. It is going to have gravity, it is going to have impact, it is already having that. But most importantly, for people like Rosie and Hayley, thank you, and Martin and Gillian and many others people that are eloquently representing the 55,000 people that go through sexual assault referral centres in any one year, slightly went down during COVID, then this is a chance for us to really grow, support and develop this as we go along. I've got a few slides today, but I'm going to skip over them very quickly because I think after the presentations today, what I think I've been asked to do is give a little bit of a health perspective about what that means within sexual assault referral centres, domestic abuse, policy, statutory requirements, but the NHS. What that means in partnerships and collaboration, but really importantly, why the new landscape of NHS England is a really key opportunity, which I've discussed with a few people this morning. So the NHS is really good at changing its clothes and its furniture, and it's done it again. So in July 1st, 2022, we have new legislation. We're very young into this. I was standing on a platform only last week with Amanda Pritchard, the Chief Exec, talking about basically the whole impact of that new integrated care board system and the opportunities that it presents. Now, Amanda, I am sure, will be the first to say that she was standing up there talking about acute trust, primary care, mental health, and the whole element of what that means across a range of services, particularly very specialised cancer services, for example. I'm standing here saying that actually very proudly the NHS commissioned the 47, sorry, I'll get my numbers right in a minute, 47 sexual assault referral centres along with obviously police and crime commissioners. But actually alongside the new 42, so there's 2 numbers here, 47 sexual assault services and 42 integrated care boards, we've got a really fantastic opportunity to look at those objectives that you can see there around improving outcomes in population health and healthcare, tackling inequalities and outcomes, experience and access, put this on the frame of what we've been hearing this morning. Enhancing productivity and value for money. That is really important because this is blooming cheap, quite frankly, when it comes to the care and the quality and the need that is still untouched. And help the NHS support broader social and economic development. So recovery, reforming, resilience and respect are those kind of watchwords that are really part of what this means. And this means this coming out of COVID as well. So we'll make quite sure that these are available to people. I know people are kind of taking photographs and everything, but these can be shared, so do not worry. So I think it's really important to say, where do those 42 integrated care boards sit within the population of the health community? It's for you, it's for me, it's for our families, it's for our children, it's for the population that live in those areas. And we were only here, Esther and I, looking at the Hodge Hill Birmingham site recently, and its new developments, its new paediatric service. I was in Bristol yesterday, looking at the One Women's Centre, which is supporting women in one of the prisons around sexual assault and abuse and health and wellbeing. I was in Catterick last week in Yorkshire, working with not only the community and the Integrated Care Board, but also the Defence Medical Services for the MOD and the Armed Forces around the SARC developments, particularly around military and sexual violence within that particular cohort pathway. So it is really important that these opportunities, these lessons learned, awful overused range, but absolutely the evidence that comes out of the work is really embedded in what we do next. So we know that at the same time as commissioning the work, we were also developing for the first time, this is groundbreakingly the first time, the sexual assault and abuse strategy. Many thanks to lived experience providers, clinicians, and many people that have tirelessly supported what was 18 months worth of work that then came up with that SARC strategy that was published and championed by the then Sir Simon Stevens, Chief Executive of NHS England. Because basically what the SARC was saying, and a number of people have said this morning, it's about lifelong care. It's about how the NHS, how health and social care services, how wellbeing and public health services are supporting people all the way through, whether that's being victims of child rape and sexual assault, whether that's adult survivors, whether that's recent day victims, or whether that's non-recent events. And quite often we know with SARCs people come on average maybe 6 years after the event, in inverted commas, of their experience. So I think the strategy and the aims in the strategy is strengthening the approach to prevention and promoting safeguarding and safety and protection of the welfare of victims and survivors, improving victims and survivors in the development and improvement of services, and that's what we're doing here, inducing consistent quality standards and driving collaboration and reducing fragmentation will ensure that we also get the appropriately trained workforce. How many times have we heard this morning that it was actually the individual approach, it was the care and support that someone said, it's okay, we're here for you. Yes, it does matter. Yes, we do believe you. Yes, we know how horrid this must feel. We also know what this means for you to get that support for the rest of your life. So those are the elements that we are still working with as part of health policy, but refreshing actually this strategy. We're taking a little bit of time with the advice of our lived experience group particularly and our team to take a little bit more time to see how we can get some of the statutory duties that the government at last have produced as part of the Domestic Abuse Act, Violence Against Women and Girls and Victims Strategy, to name but a few, to support what this means to get additional clout and power. But actually, this evaluation and this research is absolutely the key to add to that as part of the work that we need to do within the health system. So we do know that we've commissioned a lot more as part of paediatrics, children and young people, and adult services going forward, and that key commitment to increasing investment is still there. It's probably peanuts when it comes to the bigger investment within NHS England. We've heard lots of lovely figures around fiscal and budget statements recently, 157 billion, I think, within the NHS, but that is the point, because this is a two-pronged approach. So the 42 million that is commissioned to deliver 47 SARCs, the 20 million of additional funding, which is there to support the continuation of embedded lived experience, clinical leadership, but also enhanced pathways for mental health services and psychosocial, clear message from today, is there to actually ensure that 157 billion gets it right. And that's the two-pronged approach. You need the specialism, yeah, but you also need to ensure that you continue with what that means for that brilliant PowerPoint slide that was done earlier around 4 columns of experience. Great that the SARC looked pretty positive, not so great that the NHS needs to support and improve itself, but also how do we build on good practice? How do we build on collaboration with policing, with the voluntary sector, with lived experience, with clinical need, also with clinical and prescribing need, but also with lifelong therapeutic support as well. Okay, I'm watching the time, I promise. Okay, so we know that as part of enhancing the provision that you've been telling us about, we've actually been working and supporting the increased long-term plan requirements of the NHS around enhanced mental health services and collaboration with the third sector, and the improvement as we go through this over the next 3 years, including what we've heard, this will influence it greatly around psychosocial. So this is taken a little bit of a pause because of COVID. We have to be honest and say there has been delays. But we absolutely know that this is also essential for the recommendations and the voice and the care that we need to continue to build on and grow as we go forward. One of the things that we've also done, which I hope that the majority of you may be aware of, and if you're not, don't worry about it, is a campaign around sexual assault services. Turn to us, we are here. We were pretty stunned and amazed actually at how the 3-month campaign absolutely benefited not only thousands but millions of people in the feedback that we've got from social media, from individuals and from different elements of the campaign. We did, and you have said this again, support and target what that means for Black and Asian females in a particular age group, particularly men and boys, which continue to be the fastest growing percentage of people accessing some of our sexual assault referral centres, and also what that means for LGBT men and women, and also how that support is absolutely, that's there for me. In addition, we did some additional work focusing on one of the regions so that we could actually look also at the same time how that commissioning model could be improved as part of collaboration and communication, which is one of the key messages for children and people. Excellent part of this study and really important, and something that I think has probably been the biggest gap in many respects as part of the voice as we go forward. So we know from the campaign that we got a lot of media coverage, we got a lot of push, we got a lot of social media posts, we did some great work on videos and campaigns, which you have done today, and we've also made quite sure that our NHS website is absolutely key when someone wants to download and wants to follow. You know, I've got a friend and a family member that absolutely did that went to the website, looked at the area, I'm pleased to say knew the colour of the front door, as I call it, of their SARC within hours. So, that element of universities is also key. We actually did a second piece of work with the campaign because of the feedback of doing more with universities. That figure of 13, 15%, I can't remember quite now, I just let it ahead, of students also that are coming through from colleges and universities is something that I think we absolutely need to focus on more, and the messages are clear. So, the value of the research, the value of the campaign, the value of the work that we're doing with the long-term plan is part of the health policies and the work that we need to do going forward. I think it is really, really key that we start to work very closely with the Integrated Care Board. That is where that 157 billion on the whole goes to as part of commissioning our healthcare services, but also saying what does that mean under their statutory duties and requirements. We know that, like in all areas of the NHS in COVID, that recovery and reset is crucial. We saw a decrease in people coming to SARCs, we saw an increase in digital support, we also saw an increase in the request for continuing digital support, but we also know that it's absolutely important to have therapeutic and in-person and individual tailored care, and this just demonstrates some of those findings as we've gone forward. We also know, and it's come across over and over again this morning, that it's important to look at sexual violence on its own and in its entirety. But it is also important to look at where domestic abuse and sexual violence programmes can work better together as well as apart together, if that makes sense. So I think what we're also doing as part of the commissioning of sexual assault referral centres and pathways of mental health and therapeutic services is also a programme of work. At the moment it's limited for 2 years, but we're pretty confident that we'll be able to extend that in actually seeing how the rest of the NHS, that third column, can be supported around training, around employment. We employ the biggest group of people when we did the campaign. I think for Angie and I, one of the things that we were really surprised about, probably not surprised is the wrong word, but the level was a surprise of men and women who staff in the NHS saying, can I talk to you, that's me? And that was consistent throughout the campaign and still continues. But the leadership, the best practice in this room today as part of the evaluation, please can we build on that? I know there's a long way to go. I know there is fragmentation, and I know that Jess Phillips was meant to be here today and she will be talking about fragmentation. I absolutely get that. But actually, what really has mattered is building on experiences, building on positivity of actually how this matters and how we can make this work as we go forward for the future. My last slide. So let's not forget that with the passion, with the creativity, with lived experience, with the care, even with the funding, there is now new legislation and strategic frameworks that this is a moment in time going through a report title that actually Theresa May has been responsible for since she has no longer been in government, and actually was the Home Secretary that put a lot of this legislation in place as a woman. Then it is really important that we use this statutory work to say what we're doing. I can not announce, because I wouldn't be allowed to do that, but I can say that only yesterday we managed to get some agreement between the Home Office and the Department of Health and Social Care for additional funding for integrated care boards, every single one of them, to support their requirements around the prevention of serious violence and their statutory duties. Watch this space. So thank you. I feel like one of those people that kind of planted a seed some time ago, and I've been watching it blossom for some time, and it's looking pretty amazing today in this room, however difficult it is sometimes to hear the messages that we're hearing. Keep going, keep working. There's some amazing talent in this room that I hope will be the leaders for the future as well in this area of work. This is also a great place to work, a great place to have a career, but hopefully lifelong for survivors and victims as we go forward. Thank you.
Thank you both Kate and Natalie for your very inspiring talks. And we don't have much time, we've sort of eaten into the lunch break. So we're going to take just 2 questions for either or both of our speakers. Who would like to ask a question or make a comment? No, everyone's looking forward to lunch. Yeah, there should be more time in the afternoon to chat. Oh, Hetty, we have a question from Hetty. Who's the boy?
Thank you. I've got quite a loud voice, so I'll just shout. I'm a commissioner in public health in the local authority, and sexual health services is part of the area that I commission, and previously commissioned the SAR before HSC, so I've got a passionate interest in this. I'm just interested in the words that you said about ICBs taking this seriously, because it seems to be difficult to get at a national level the sexual health commissioning exec that I'm on, and to even take notice about sexual health services. So I'm really heartened by what you say about what you can't announce and what happened yesterday. And it's a plea really for this to be taken seriously, all of this agenda. And I just hope that what you can't say and probably will say later will really be influential in changing that, because it's really hard at ICBs to get them to take notice of these very important issues. They're very focused on waiting times, the backlog, COVID. I won't say anything else, I could, but I'll get sacked. So I really do think that this is promising, and this research is promising for that. It's an evidence base. So I'm starting to feel a bit hopeful about ICBs. I wasn't yesterday.
I don't need to answer because it was very eloquently put, and I just would say it's not my apology, but I think one of the worst things that have come out of COVID has been the misunderstanding, the demise of how public health plays a complete and utter central role to that. I think this is coming back. I think that's an important element. I think that's part of the sort of the bump in the road, but let's keep going.
Okay, so we might leave it there. Please join me in thanking our people. Oh, we have one more question. Sorry, Dan.
Hi, yes, I'm Diane Whitfield, and I've been involved in rape crisis in Wales for many years, but I'm also involved in the local ICB. And what I do know is how financially challenged the envelope is for ICBs moving forward. And I'm just asking whether or not there are ideas about ring fencing, funds specifically targeted for domestic violence and sexual abuse survivors in this, because otherwise it's going to be a bum fight.
I don't think the microphone is working, but hopefully I've got a booming voice. I've always wanted to be on the West End cabaret, probably Roxy Park, but anyway, we'll go with there another day. As part of the ICBs, I think you're absolutely right. Nobody's going to say that the NHS isn't absolutely up against it, as is the public sector. I think what we have got, because of the great work of people like Julian Kelly, who supported us as part of our journey within commissioning and the growth of sexual assault services, is a better settlement than we expected last Thursday, or the week last Thursday. So we are still looking at prevention, we are still looking at innovation, we are still looking at collaboration. We also do need more resources. I don't disagree with you at all. I do think there's an awful lot we can do without money as well, and with the current money we've got. So, the work that's happening within primary care and also with acute settings and particularly mental health, there needs to be much more recognition of what's already happening, along with the evidence of this kind of study to say what you're doing needs to be better in the way that it was modelled around the needs of victims of rape and sexual assault. Now, that's not me trying to get away from saying that resources wouldn't be ideal. And the growth of sexual assault services funding is quite significant when you look at it in percentage terms. So other areas, but it's quite small in funding. In the new legislation, we are actually, we're not allowed to use the word ring fencing, by the way, but we are accountable and responsible for direct commissioning of sexual assault services. One of the reasons it's not being delegated or devolved to the integrated care board is because we don't want it to be fragmented. We don't want it, it's not an awful lot of money, it could get kind of lost somewhere. So there is an element of ring fencing. And certainly at the moment, the work that we're doing on the programme of work around domestic abuse and sexual violence is also ring fenced as part of the next